going to the hospital and then having not so great outcomes when they get there, or just having frustration in general about going to the hospital and having many healthcare providers not really understand ALS, and we didn't know what questions to ask or what things to do, that sort of thing. And so we've kind of looked at a couple different perspectives, and it would be incredibly hard for us to go to every hospital system and train every ER staff. So we're approaching it from this aspect of let's train patients and caregivers, and hopefully give you guys the tools to advocate for yourself if ever you are in an emergency situation, so that you at least know a little bit better about questions to ask or things like that in those sorts of situations. So what is considered an emergency? Certainly we've talked about a situation when if you have a fall and you just can't get off the ground, and it, maybe I just kind of slid down to the floor, or, the legs gave out or whatever. And we always encourage you to call the fire department. That certainly can still happen. However, there are times when a fall really becomes a more important situation where you need to probably get checked out. So clearly, if you hit your head, we want to make sure that you're not bleeding or anything like that. If you are hitting another body part and you notice some swelling or that sort of thing, clearly that can be an indicator that maybe you've sprained something, maybe you've broken something, any of those sorts of things that really need to be paid attention to. If you or your person or whoever is on a blood thinner, that's an automatic. You need to go just get checked out. I don't know how many patients we do have on blood thinners, but certainly when our patients are becoming more immobile and are in things like power wheelchairs, they're not walking as much, so they can be prone to blood clots, things like DVTs, blood clots in your legs and things like that. And so sometimes they are on blood thinners. So if there's a blood thinner at all, without question, just go get it checked out. If you're choking, there are patients of ours that have bulbar issues. They have problems with swallowing, food, fluids, pills, things like that. Clearly, we know that sometimes that's an ongoing issue. But if you're having a situation where something is really stuck to the point where they become unconscious, sometimes we have lots of secretions that get very thick that Rondo will probably cover a little bit later, but there are things called mucus plugs. Those things can't really come out when you're doing coughing and things like that. So if you're getting to that point where the person has really got something stuck and there's not air movement at all, or they're losing consciousness, then certainly that's the time to call 911 emergency. Cardiac events, obviously, just because they have ALS doesn't mean that there isn't something possibly wrong with their heart. If they have a heart attack, that sort of thing, maybe very high blood pressure, or you're noticing some loss of consciousness or acute level of confusion or that sort of thing, then we want to call 911. Respiratory distress that's more than what your respiratory equipment is going to handle at home, right? Rondo's going to talk about if you have shortness of breath and you have a bilevel at home, obviously we want to put that on first, right? Is that going to give the patient some relief so that they can breathe? But if you've already got that bilevel on and you're still feeling short of breath, or the patient is very short of breath and you don't know what's going on, then maybe it's time to call 911. Now, always the caveat is, have I signed a DNR? Do I not want mechanical ventilation, trached, that sort of thing? This is not taking into account those sorts of things. We're just talking about, in general, if you're in respiratory distress and you do want to find out what's going on, then if those pieces of respiratory equipment that you have at home, if they are not working to relieve that, then is it time to call 911? Do you want to go seek some sort of treatment for it? And then obviously neurological events that are Something different than ALS. Did you have a stroke? Is it a TIA? A TIA is like a mini stroke. You know, are they slurring their speech and that is not typical of their ALS? Did something acutely happen where something is not quite right? Is there acute confusion? You know, that sort of thing. Then there are planned visits, right? We even need to talk about that too. If you've got a planned visit that is coming up, you know that you're getting a feeding tube placed. You have the visit with the GI doctor, and that's coming up in a couple weeks or whatever. You know, what do we need to do to prepare for that visit? If you have decided to get a tracheotomy and go on mechanical ventilation, lots of times patients will prepare for that ahead of time. It's not always a respiratory distress thing. They can plan for it and go in for that procedure. So there are some elective procedures for ALS patients. There are also elective procedures like, I need my knee replaced, I'm getting a hip replacement, or whatever. You know, just because you have ALS doesn't mean there aren't other things that happen. Sometimes we have patients that fall and, oops, I broke my wrist and now I have to go have a cast put on or whatever, those sorts of things. COVID is clearly still a thing. You know, are we going in because we have a fever, we tested positive and we're really feeling bad and we need to go in for IV fluids or some sort of antibiotics or whatever it is. Also the flu, you know, sometimes flu can hit patients with ALS and it's a lot worse than before we had ALS, and they really have some issues where they're feeling very bad. They get very weak. They do need fluids, antibiotics, whatever, those sorts of things. Then obviously, like, is there just some sort of general feeling of unwell and I don't know what it is? Is it a fever that won't go away and I don't know why? Are they not eating? Is it anything where you're like, I don't know what's going on and this has been going on for 2 or 3 days or whatever? It's something to warrant going into a hospital. So that is still something that we want to talk about. What do we bring? So you don't just lots of time walk out the door, right? Like, there are things that we need to bring with us. So one of the things that we talk about when we're in caregiver skills to the caregivers is planning ahead. And we talk about bringing this thing called a go bag, which everybody should have at their home already prepared. So this could be, what if you have a fire at your house? What if you're in a situation where you're in an area and there's a monsoon and there's a flood? And what if there is a power failure and you have electricity that goes out for several hours and you have equipment that you need electricity for and it's forcing you to go to another place? So we always want you to have these things in the go bag. And I need to come over here because I can't see the whole thing. So obviously copies of your insurance card, medical insurance card for sure. If it was a fire or something, you might even want to have like homeowners insurance and things like that in here as well. Have an emergency contact list. Who are your physicians? Who are your emergency contacts? Lots of times your emergency contact is your spouse, but are there adult children or things like that that also need to be notified if there is an emergency? Put your medication list in here. If there is a true emergency or whatever, lots of times you're running out of the house. You're not grabbing the medication containers or, you know, your pill box, things like that. So have that written down in here. If you are taking equipment with you, is there instructions attached to it that tell somebody how to use it? So if it's your power wheelchair, if it's a cough assist, if it's a bi-level machine, if it's any of those things that require somebody to use it and the person that normally uses it isn't with you, can somebody else operate it for you? So we always say, like, put an index card attached to it or something like that so somebody else knows how to use this piece of equipment. Lots of times a pharmacy will give you an emergency supply of medications if you run out and don't have it. But if you can, put a 7-day supply of your medications in this bag. If your person has problems with communication, always make sure you have some device, some form of communication that an alternate form that they can use. So if they can't talk, but they're still using their hands, do we put a boogie board in here? That sort of thing. Do we need to just put an alphabet board in there so they can point to letters? Do you use one of our speak books? Something. If they're definitely using an eye gaze machine and you run out without the eye gaze, then we need an alternate way to be able to communicate with the person. Nutrition. So if your person has a feeding tube, can you put a couple cans of formula in there at least? Obviously, a couple bottles of water. If a person takes time to fill out advance directives, you must have a copy with you. In the state of Arizona, any medical professional is going to do everything they can to save a life. If your person took the time to say, these are the things that I don't want done, and they did all that paperwork, you have to have that paper in front of that medical professional to prove it, or they are still going to try to save a life. So put a copy of advance directives in here. Hand sanitizer is kind of a given, like you don't know where you're going to go or where you're going to be. If your person is incontinent at all, or they use things like a urinal or Depends or things like that, put that in there. Everybody runs out with their phone, but they forget the charger, so maybe an extra charger in there. For whatever reason, patients always complain of cold feet and hands usually, so throw some socks in there. You might have to write down instructions, so pen and paper. Sometimes it might be good to put some cash in there because not everybody's running out with their wallet or their purse, or if it's a true emergency or 911 shows up and they're like, we're throwing you in the back of the ambulance, let's go. You're not like, wait, let me go get my purse. Let me. And then obviously maybe just some snacks, things like that that you want. So this is just a concise little thing that you can take with you that has a lot of stuff in it. If you are already on respiratory equipment and you're going in for an elective procedure for sure, we're always going to recommend that you take that equipment with you. Lots of times, obviously, your equipment is already on your settings, so why not use what you're used to, right? Most places, Rondo will talk about, will let you use your equipment. Lots of times they'll have to have an order from the doctor that says okay to use home equipment or whatever. But most places will let you use your own equipment. So if you have it and it's something planned, certainly plan to take that equipment with you. I think Rondo will mention today too that lots of hospitals don't have cough assists. Mm-hmm. So if you use that on a daily basis, that is definitely something that you're going to want to take. Obviously, if you're on a feeding tube or your person has a feeding tube, most hospitals have formula, but if you're on a special kind of formula, like we have a lot of patients that choose Kate Farms. It's very natural, that sort of thing. Hospitals don't have Kate Farms. So, I mean, it's not like another formula isn't going to be okay, but let's just talk about formula in general. If your body's used to one type and you go on another one, what's going to happen? Diarrhea, probably, right? So if you have what you're used to, take it with you, especially if it's something that probably the hospital is not going to stock. It would be to your advantage to take it. And you don't have to be like, oh my gosh, we're leaving, but let me grab a case of this. Like, just grab a couple. You can go to the hospital, and then if you know they're going to be admitted or whatever, you can always go back home and grab more or ask them if they can order that particular formula. But at least you've got a couple to get you by for the immediate time frame. So what do you ask when you're there? We have a lot of patients that if they get admitted for sure, they're like, well, they threw me in a room and nobody came to see me. Nobody came to help me. I felt like I was at the end of the hall or whatever, and nobody ever came to check on me. We all know that hospitals, nursing homes, any of those places are chronically short-staffed right now, right? So personally, I feel like, you know, the squeaky wheel gets the oil kind of thing. And what if you're not a squeaky wheel? What if you literally can't squeak? They're just going to assume that, oh, well, that person's fine. They can't move. They're in bed. I don't have to do anything for them, right? Especially if our person cannot verbalize. So just the call lights that they have in the room, sometimes that button is not easy for patients to push. So you need to ask them, do you have alternate options if that button is too hard for your person to press? They do have alternate call light options, so you need to ask. If they say, nope, we don't, We do have alternate call light options here, so certainly call our office and see if we have some in stock. Some of those options are, you barely have to press, and it's just a metal pad. So we can put it on a pillow, we can put it beside the foot, like literally just tapping at all will initiate that, that call. It will sound, it won't press a light, but it'll at least give a sound so that they're coming into the room. We always ask to be close to the nurse's station so that at least you would think that the nurses are at least looking in on the room and checking more closely. Ask if you sleep in your chair, if you're in your chair all the time, those sorts of things. Ask if you can have it in the hospital with you, especially if you're being admitted and you're going to be there a couple days or whatever. Most hospitals will say yes, you can bring it in if you can get it there. And if you don't have the access to get it there, certainly call our office. I'm sure that we can find out a way to get a chair to the hospital for you if we need to do that. Many of our patients spend 24 hours a day in their chair. So I would rather you be comfortable in your chair than miserable in a hospital bed, right? So ask if you can bring your power wheelchair with you. If you feel more comfortable, ask if your caregiver can stay with you in your room. If that means that you need to ask for a private room, certainly ask for that. They might say, no, we have is a semi-private, but you're still more than welcome to stay if you want to, or if the other person in the room says it's okay. But if you feel more comfortable having your caregiver there, ask for that. Sometimes you can even ask them if they will allow, if they, like, I don't know if it's still going on right now, but sometimes it's, flu season and they don't want extra people in the hospital bringing in germs and things like that. You can always ask, could I have a sitter stay with me? So that at least somebody is by my bed and able to assist if you won't allow the caregiver there. If you have that respiratory equipment that you brought in, ask them, can you get an order from the doctor so that I can use my own respiratory equipment? And then we talked about the alternate communication options. If you need that, they need to know, I can't verbalize. I need a nurse to check on me every hour because I'm not verbal. I have to use a speak book. I have to use whatever. I can only write on a boogie board or those sorts of things. You have to remind them of those sorts of things. Okay, so we've had lots of patients that have had problems with this. They get a feeding tube placed and then they go home and nobody gave them any instruction on anything. And they called the office and they're like, what do I do with this? I don't know how to use it. Nobody gave me anything. This drives me crazy because I don't understand how you can discharge somebody with no education. But so please ask if your person is going in for a feeding tube placement, whether it's an elective procedure or urgent, and you go into the hospital because there's been some choking event or something like that. While you're in there, ask somebody to teach you how to use it. A nurse should be able to do it. A dietitian should be able to do it. A speech therapist should be able to do it. Multiple people in the hospital should be able to teach you how to use that feeding tube. Even if you're getting a feeding tube placed because maybe your respiratory status isn't great and you just need it, we're putting it in proactively, you still need to know how to flush it, right? Like it still needs flushed with water. So you need to be instructed at least on how to do that. I've heard in the past, a home health nurse was always arranged to come to the home afterwards just to maybe make sure that, do you remember everything they told you in the hospital? I've heard recently that insurance is not paying for that. So I'm not sure if that's the case or not, but I would ask, like, is anybody coming out? Most times if formula is being delivered, it used to come with a nurse who would say, is everything okay? Let me check the tube, that sort of thing, but it might not be happening anymore, which is even more reason why you need to be taught in the hospital. I would make sure if you are getting this because you need that nutrition that you're asking, has the formula been ordered so that I am getting it when I get home? I know if you are a Barrow patient, you're getting that education done by Jordan and they're making all of those arrangements for you. So even though you're going to a separate GI doctor to have the tube placed, Barrow's making all of those arrangements. I don't know that it's happening for every other ALS clinic. So you need to be asking, are you guys doing this for me? Is the GI doctor doing it? Probably not. It's probably your speech therapist or your dietitian at your clinic that should be ordering the formula. And then, am I going home with supplies? At the very minimum, they should be sending you home with a syringe so that you can flush the tube, right? So you need to be asking, can I have a syringe to go home? There are little gauze pads that go around the tube. You don't have to continue to use them at home, but hey, when you're in the hospital, ask for some. Ask for a handful before you go home, that sort of thing. And then I always want to know, do you have a follow-up with your GI doctor? I can't tell you how many people say, nope, no follow-up appointment with GI doctor. Well, the initial tube that's put in usually isn't the one that stays forever. Doesn't have to stay forever. It can be replaced with a tube that's flush with your belly, like a Mickey or something like that, which means it has to be changed by somebody, which is the GI doctor. So I would be asking, if you're having that consultation for the feeding tube, when am I following up with you? A lot of it depends on which kind of tube you're getting, but that hole that they put in your belly is called a stoma. And that stoma has to heal before they can change it out. And it depends on what kind of tube that they put in, on what that length of time kind of is. It's usually anywhere from 3 to 9 months before you can get a different type of tube. So I would be asking those questions from the GI doctor. Even if you go in urgently, a GI doctor still put it in. I'd be asking the nurse, like, hey, I need a follow-up appointment with this GI doctor before I get discharged. Okay, take it away, Rondo.
All right, so she talked a lot about respiratory equipment. I know some of you, I don't know all of you, so I'm not sure who all has respiratory equipment. But one of the biggest recommendations I can give you is that if you do use a bilevel, a cough assist, not necessarily suction, but at least bilevel and cough assist, or you have a non-invasive ventilator, any of those things, is to take it with you. And the reason why is, if you're used to that equipment and they try to put you on something different, it's not going to feel the same for you. And if you're going there for respiratory distress or anything and they try to put you on a different type of machine, that can cause a lot of issues. So as Janie mentioned earlier, usually they'll let you have your own equipment as long as the attending doctor at the hospital says and writes an order for it. Now, with that being said, a lot of the respiratory therapists at the hospital are not going to make adjustments to your machine or anything because they're not trained on them. But they should have some knowledge about it. You could also always reach out to me, reach out to Demi if you have any issues while you are there. But unfortunately, we've had a lot of people go and they don't take their equipment, and then they cannot adapt to the equipment at the hospital. So that's something that's really important, is to take your stuff, whether you're going in for, like Janie said, an emergent situation, or if you're going in for elective, like a tube placement or, you know, a knee replacement, anything like that. Hopefully you won't need something coming out of anesthesia, but you may, and it's much more comfortable if you're on your own stuff. Okay. And if you are going to have an elective procedure like that, it's always good to reach out to your RT at clinic or to me or to your physician and say, hey, I'm going in for this. What do you think I should take? And, you know, what do I need to be aware of in that situation? Because we don't want you getting there and then just putting you on straight oxygen, you know, or something like that, which I'll talk a little bit about too. Another issue is many people, if they're having respiratory distress, they're not able to lay flat. And a lot of times in the hospital, they're going to lay you flat for certain procedures, like if you go for x-rays or MRIs, or even just in the hospital bed itself. So you need to advocate that I cannot lay flat. Okay. Now, if you are able to be on your bilevel or non-invasive ventilation, you can lay flat, that's fine. But if it's uncomfortable for you, they can work around that. They'll tell you, oh, we need to lay you flat. Say, absolutely not, because that is really, really difficult for some people. So one of the biggest things I could say is speak up, have yourself, or if you're not able to, is to have that family member or caregiver be able to speak up for you, because you really have to advocate in the hospital. You get there and you think, oh, they know what they're doing, and they are good at what they do, but they don't necessarily know ALS. And respiratory is much different in ALS than it is in other situations, okay? So the part about do not use oxygen alone, I talk about this a lot because people don't understand it. Anytime you have a breathing problem, most people are like, yeah, give them O2 because that's what we do in an emergency situation. And it's true. A lot of times you do need oxygen, but when you have ALS, you typically do not have an oxygenation problem, you have a ventilation problem. And what that means is that if you're not able to get the air in to get the good oxygen exchange that's at the very bottom of your lungs. If you were able to do that, then you would oxygenate fine. And so what we mean by ventilating somebody is that you're able to get the air in so that you get good oxygen exchange. That goes to your heart. The heart pumps it to all your organs and tissues, and your oxygen saturations are typically good. The second part of ventilation is being able to exhale to get rid of your CO2, okay? We need to get rid of that CO2. Retaining CO2 actually suppresses our respiratory system, causes fatigue, causes confusion, lethargy, headaches, all of those things. And people think, oh, somebody's just resting comfortably, when they really aren't. They're retaining their CO2 and their respiratory drive is going down, which then can cause them to actually go into respiratory distress. So it's really important for ALS is that we help that diaphragm out, and that's usually what we do by using non-invasive ventilation, bilevels, vents, those types of things, okay? And I use the term bilevel just so y'all know. You hear it a lot out there called BiPAP. That's actually a trade name for a machine by Respironics that is actually no longer even being made. However, they're all bilevel therapy, so I'm sorry if I'm confusing anybody, but that's what we call it around here. So the reason, again, that you don't want to just use oxygen alone, and it's a common thing, you're going in with respiratory distress, you're having trouble breathing, your oxygen saturations are low, so the EMTs, the hospital staff, boom, throw you on a mask of oxygen. Well, the problem is that, again, you're not ventilating. So the oxygen is going in, but it actually then tricks your brain into thinking, okay, you have enough oxygen, and it even suppresses your respiratory system more. So it kicks you into what we call hypoxic drive, again, slowing down your whole entire ventilation process, which would cause you to go into respiratory distress. So with that being said, in emergency situations, sometimes oxygen is needed, especially if somebody has a pneumonia or it's just a really acute situation. But you want to have them use oxygen in conjunction with your ventilation therapy, okay? Whether that, again, be bilevel, or some people confuse it with the bilevel therapy with vents because they're using a vent at home but with a mask. So the term NIV stands for non-invasive ventilation. That pretty much covers everything. That's bilevel therapy, mask ventilation, all of those things, okay? So again, it's okay to use oxygen if they are ventilating you, but not to use straight oxygen, okay? Another thing that we would like for them to do is to frequently monitor the CO2 levels, because I do see this all the time. Like sometimes people are just using bilevel therapy at night and not on it during the day. But again, the hospital want to throw them on oxygen for a comfort measure, again, not understanding, and their CO2 levels are climbing. So we want them to be able to frequently monitor the CO2s. There's a couple ways that you can do that. One is by a blood gas, which is a stick with a needle, which most people don't like, but that's the most accurate thing. And they can do that, occasionally, and it's not that bad. But they also have what we call end-tidal CO2 levels, which is just kind of a breathing type of mechanism where they can check that as well. So we want, if your CO2 levels are climbing, that means you need to go on some type of ventilation therapy, okay? Again, we already kind of talked about it, but use your home NIV in settings if they allow you to, all right? Now, sometimes, again, especially if it's an acute situation, and let's say you're on a bilevel at 10/3 at home, but you're really struggling to breathe, we may need to go up on pressures. I'm not saying, we need to do that. So again, that's why you want to contact either, your doctor, your respiratory therapist at clinic. You can reach out to me and we can go over all of that stuff, because I want to make sure that you're getting the correct settings and pressures that you need at the hospital. But you don't want them to come in and throw you on a setting that they do for somebody that doesn't have ALS, because then that could be harmful to you and definitely not helpful a lot of times. All right. If they have questions at all, we always recommend to call your ALS neurologist. And we see it all the time. It's unfortunate, but the hospitals have neurologists, but they have actually zero experience with ALS or very little experience with ALS, and you're shaking your head because I'm sure you've probably experienced it, and I apologize about that. They're doing the best, but they don't know it. Have them call. Anytime you're going to go to the hospital or get admitted, please call your clinic and let them know so that that doctor can consult with the team at the hospital. And then cough assist. Are y'all, anybody familiar with cough assist? I know you are. Okay. So cough assist is a very, very important piece of equipment when it comes to respiratory. The hospitals don't have them. And a lot of times they'll go, what? Like they have no idea what it even is. So if you're in respiratory distress or even anything else, and you're typically using a cough assist 2 to 3 times at home, but you go into the hospital and then they're not going to help you out with that, you're going to start retaining secretions and it could become dangerous. You could get a mucus plug and those types of things. So bring your cough assist machine with you. They may not do the treatment on you. I'll tell you that right now. A lot of times they're like, we're not trained in that. We can't do it. It'll be up to caregiver or family member. But again, have that doctor write the order for it, and then they will allow you to do it. And definitely advocate for that, because I see that that's a huge problem in the hospitals, unfortunately. And people, they don't understand that you're not able to cough because you can't get that big, deep breath in. And then also just all the bulbar issues that can occur. And so even if you could, you can't cough it out. And so you want to tell them, I got to use it. And if they again say, look, we're not doing that, say, that's all right, I'll do it. Just make sure there's an order for it. Okay. And with that, typically, and those of you that know me, I always preach about always having your suction machine with you when you have a cough assist. You can take it with you, but the hospitals all have piped in room suction, which is much, much better than your little portable ones at home. But make sure that they understand that. And also, if you use it frequently, or if you're having a lot of drooling, make sure you have a Yankar that's not vented, and have them, have it on the board, have it anywhere, like, hey, needs mouth, suctioned every hour, every 30 minutes, whatever it is. Whatever your needs are there, please just don't feel like you have to just be quiet and assume they know what they're doing. You guys know yourselves and your people the best, so advocate for them. It's probably the biggest thing that I can say. Don't ever feel like they know, because they probably don't. Some do, some don't. So I think that's it for that part.
Okay, Lindsay, will you pass this around?
Yeah, absolutely.
Okay. When you say respiratory distress, by definition, what is it?
So as Janie was explaining earlier, it's something different than what your person or you are typically feeling. So if you're not on any respiratory equipment or any, bilevel therapy, cough assist, anything like that, and you're having trouble breathing, meaning you can't get a full breath in, perhaps you have an oximeter at home, you're checking oxygen saturations, they're less than 92%, or somebody feels like they have phlegm in their throat, or you can hear it and they're not able to clear that. Those are all respiratory, I don't want to say arrest, but respiratory distress, okay? Something that's different for them. If you notice that their work of breathing is getting much harder, or if they seem like they're just kind of sleepy, but they're not really waking up and their respirations are very, very shallow, again, that's CO2 retention, where their respiratory drive is being depleted, and that would be an issue where you'd need to call them. Now, if you're on respiratory equipment, such as bilevel or anything like that, and you're on the machine, but you're just feeling like it's not working, like I'm not getting enough air, I feel like I'm having to pull in, again, the saturations are low. If you see people using a lot of accessory muscles to breathe, in other words, you might see them like this, they could be caving in here, caving in, by the ribs and stuff, that's all a respiratory situation. And of course, anything with choking with secretions. Okay, so you always want to try, if it is a situation with secretions, is to do the cough assist, and you may need to do it a couple of times in a row, not just, my typical thing where I say 5 cycles in 5 sequences. You may need to do it several times to try to get whatever's in there to pass. But if you can't and it's not working, that's definitely a respiratory situation where you want to, get some help. Okay, does that make sense? Okay, good.
What Lindsay handed out here, and just for everybody that's going to be on the video that's recorded, we will have these in the office. So if anybody wants them, they can call the office. But we came up with this in hopes that you put this in the go bag as well and can show medical staff when you get to wherever it is that you're going, whether it's in urgent care, whether it's the ER, anything. It's meant to show them, listen, this is part of my problem and this is what you need to know. And we've even asked patients, like, if you get admitted, put it above your hospital bed or those sorts of things so that everybody knows what is going on. There's a special note in here that says, please ask my family. They know about me. And I've literally had some families that have said, the medical professionals will say, basically, don't tell me my business. I know more about it than you do. And if that's the case, politely say, okay, and then call us. I have absolutely no problem making a phone call, going in if I need to, and helping to advocate for you. They're not being intentional. They're not trying to be rude. They really don't know ALS, and they're just trying to help you out. But until they really do understand what's going on, they might say, I know more about it than you do, which is not the case most times. So this is trying to help them understand what your specific needs are with ALS. But then if you run into those problems, certainly lean on us or your clinic team. You can always, I know that emergencies don't happen Monday through Friday, 8 to 5, right? Like, it might be 3 a.m. on a Saturday and you're not going to get any of us, right? But if it's on the weekend, feel free to reach out to us. But if it's during the week, you should be calling your clinic team first. They are your first level of care, right? They know you the best. You've got a doctor there on your team that can probably make a direct call to the attending physician that's taking care of you in the hospital. They're going to have more clout than we are, right? But we're just saying we're there as a backup in case you really need that sort of help. I have gone to the hospital on a few occasions where people have been in respiratory distress, and I've had a doctor say, listen, I don't really know anything about ALS. Tell me what to do. So that's very nice that they at least said that, And
we welcome that.
Yeah.
Actually.
And there are some doctors that say, get out of my way, but we're going to at least try to give you as much help as we can if they're pushing back. So we're hoping that this will help. We're going to put these in all new patient packets. So
yeah, and just to add to that, like Janie said, to post it up above the bed, because as you guys know, there's always different people coming in, and we need everybody to know, because they may send a nutritionist in to check on you that doesn't know anything about ALS. And if that charge nurse or your particular nurse isn't there to explain, and you're not able to speak, and your loved one has stepped out of the room or something, that's there. And one other thing that I would add on that is, if at all possible, because typically you want to have somebody with you, but we know people have to, go to the bathroom, go home and take a shower and have a break, is if somebody could always be there at shift change, that's important, because you're always going to rotate. Don't just assume that the day nurse is going to explain to the night nurse exactly how to take care of you. They may think they know how to take care of ALS, or they may think that they saw you the night before or whatever. So if possible, always try to have somebody there at shift change to explain what's happening.
Yeah. Questions? Any situations that you've run into that maybe were not addressed, or you had terrible experience? And
well, that's good.
Yeah. This is a small handful, though.
Yeah.
I have a question.
Yes.
If you need to use ventilation with O2, is there two separate pieces of machinery that are combined into a single mask to deliver those two things?
Yes, typically there is. There's a certain, if you had a ventilator out there called a Voxen, a lot of times that one will have oxygen that can, an oxygen concentrator that the button can just be pushed and it be bled in. But otherwise, typically oxygen is separate from the ventilation, either bi-level or a vent. And so it's bled in to either the mask or to the tubing. Some of them have certain O2 tubing, but if you're not used to having oxygen, you probably don't have that O2 tubing. So in an emergency, until they get that, I mean, they can put a nasal cannula or something under your mask. It's going to cause your mask to leak a little bit, but do that until we can get you the oxygen, either a connector or a special tubing. So, yeah. And again, it's usually piped in at the hospital, so you don't need an extra concentrator or anything like that. Okay. If your DME companies as well gave you instruction booklets with your equipment, as far as the cough assist and stuff, I would, like Janie said, have those kind of instructions either in the go bag or have somebody bring that with, because that can be a little bit helpful. But again, don't be alarmed if they say, yeah, we're not touching that machine. We'll let you use it, but it's up to you guys, because that's typically what I'll hear. It's a liability on their part for them to use equipment that they haven't been trained on.
Will they allow you to use drops, like for slow saliva?
So we usually recommend, like I said, to take definitely your medication list, but if you have the medications as well. Most of the times the hospitals will not let you use your own medication, but if they're unable to get it for you, there are certain circumstances where they'll write that you could use it. So yeah, and that's the other thing is, again, meds and stuff like that. If you know the atropine drops work for you or the scopolamine patch works for you, and they're like, oh no, we're going to get you this, say no, this is what I need. Just really, really, feel comfortable advocating for yourself or your person.
You mentioned too the atropine.
The scopolamine patch.
Okay.
That's another type. It's actually for motion sickness, but one of the side effects is dry mouth. And it works well for people that have really kind of thick and tenacious, a lot of secretion problems. So it's a patch that goes, behind the ear, and it usually gets switched out every 3 days. And you do. Mm-hmm. So you could talk to your clinic team about that, the respiratory therapist and or the physician.
I find the atropine, like it takes a while for it to work, and it doesn't work as well as it. But yeah, probably your body gets used to it.
Yeah, that's true, but also everybody's body reacts differently. So I wish I could say, hey, use atropine drops, use the scopolamine patch, this is going to take care of it. It's not that way, unfortunately. It's kind of a process of elimination and trying things, and sometimes, or a majority of the time, it's a combination of things, of meds for the dry mouth.
This patch, if it works, sounds like it's a lot easier if it lasts 2 or 3 days. The drops, obviously, you're doing the drops. We're probably doing the drops 3-4 times a day.
Yeah.
They gave us prescription for 4 bottles, and that was like 3 months ago, and I think we've gone through 3 already.
Yeah, and who ordered that for you?
Who did order it? Oh, it was Alana.
Barrow. Yeah, so you can talk to Rose or Jordan and just say, hey, they're not really working. Can we try something a little bit stronger? Okay. And just to kind of piggyback on that, while we're talking about for secretions, one of the most important things you could do is hydration. And everybody's like, why do I want hydration when I'm already having all these secretions? Is because hydration helps keep your secretions thin, and the thinner they are, the easier they are to move around. So, and even if you do have a lot of drooling, excess saliva, that type of thing, you still want to do good hydration and good oral care. If you're not taking stuff by mouth, as far as, any liquids or whatever, use touthettes and just really swab out the mouth once an hour, sometimes even more frequently, just to kind of keep everything moist. And a lot of people will say too, well, I've got all this saliva, but I have such dry mouth. And They're like, why is that? And it's because your secretions contain a lot of bacteria and acids and stuff, and then breathing in and out through the mouth, it dries all that stuff up. So it's real important to do good oral care, keep everything hydrated. If you are able to drink or you have a PEG, follow the recommendations of your dietitian as far as how much water you get in. And then otherwise just drink lots of water, because that will really help with the secretions. And then there's other things out there. There's glycerin sprays, and there's all kinds of natural stuff out there. Try them, you know, whatever works for you. And a lot of times, like I said, it's a combination of things, or as time goes on, you may need to change it up. Like they may have worked in the beginning, and now they're not working as much. So just add and try things. Any other questions?
For anything like that, for medications that you're on for excess saliva, for muscle spasms, for cramps, for any of those things, if you were prescribed something because of a symptom and it worked at some point in time and now it is ineffective, you should be communicating that to the clinic team, because almost all of those medications are medications that we can titrate, which means we can go up in dose, or we can use combinations of medications to make it more effective for that symptom. So if ever there is a symptom that was okay and now it's not, you should be communicating that to your team. There may be a point in time where they say, hey, we've exhausted everything and this is the way that it is, but don't assume that until they tell you that, right? There are so many medications on the market for symptoms with ALS that we want the patient to be as comfortable as possible until we've exhausted all of those efforts. So if something now becomes ineffective, be communicating that to your team for sure, no matter what it is. Other questions?
I recently received a wheelchair, and although I have a master's degree in mechanical engineering, these don't work anymore. And I can't even get it out of the box. I have some ideas of neighbors and maybe bring it down to my local garage, but.
Are you talking about a manual wheelchair or a power wheelchair? A power wheelchair, okay. Who delivered it? Is it a custom chair or was it from our loan closet?
I believe from the closet. ALS delivered it.
Okay, and they did not instruct you on how to use it at all?
I called, but nobody called.
Oh boy.
Can't get it out.
And I believe it's made in China, so it's not.
Wait, it's not a power wheelchair. If it's a power wheelchair, it's not in a box.
Those are really
Unless
big,
it's-
like what
unless
he's
it's
in.
In a box.
Maybe it's a little jazzy or something.
Or maybe, was it from Team Gleason?
Yeah, that's what we will look into that for you. Yes, you should get some instruction on that.
Yeah.
Yeah, there's different adaptable things.
Yes.
Yeah.
You don't have to always use your hand. Like there's different things where you can use your whole hand.
Yes.
You can use your foot. You can use your knee. There's different things for the power chair that you can adapt to
Yes.
how you use it too.
I will discuss it with Hannah. We will reach out for you, so, and get that taken care of. You should not have to use your degree to figure out your chair.
Yeah, and just to speak on that too, is a lot of times DME companies and stuff, we hear this all the time, so I just like to pass it along, is that the DME companies possibly don't instruct you on the equipment that they deliver, or they don't give a thorough instruct. If that is the case, please reach out to your clinic team. Don't wait 3 months until you come back to clinic. We ordered that stuff for you so you could start using it, and you need to benefit from it, hopefully. Don't wait. If somebody didn't do what they need to, get on the phone, give us a call, and we'll get somebody out there to do it. Because, as you said, it's doing you no good in the box. You know, so
Still in the box in the garage.
yeah, we can't have that.
Yeah.
We want it to, you know,
Yeah. And especially respiratory equipment, though, like they should be instructing. So, you know, it's our job as clinic team members to tell you guys, hey, don't just leave it at the doorstep. Like, come in and show me. But we're still having a lot of problems with the respiratory companies who are not doing that. So if you are not getting instruction, especially on respiratory equipment, let your clinic team know, because that's a vital piece of equipment that, you know, we ordered it for a reason, not just to collect dust.
Yeah, and I'm always available too. Either, just send me an email. That's the easiest way to get in touch with me, and I can help out with that, even if you're not, whatever clinic you're going to or whatever. I'm more than happy to help out with some of that stuff and either get the right person out there to instruct you on it, or sometimes it's just a question that you have because it's a lot of information at once. I can help you with over the phone or anything like that. So feel free to reach out anytime.
How would you know if your bypass needs any adjustments, or does it ever need adjustments?
Yeah, it does need adjusting. It depends on what type of setting the person's on and how the clinic set them up. There's, straight bilevel therapy, which is an IPAP and an EPAP. And we go up on the IPAP pressure. Sometimes it's in what we call a VAPS mode, which is more of a volume, and it's based on tidal volume where it's supposed to self-adjust. However, that still needs to be adjusted as the disease progresses and time goes on. They should be talking to you about this stuff at clinic, is one way. The other thing is if you do have respiratory equipment, it's always nice if you can take it to clinic with you, if there's an RT there that can help you out with that. But one of the main things I tell people is when you first get the equipment, and if you're instructed properly and it's at the proper settings and such, you feel satisfied. In other words, the mask is on and you feel comfortable breathing on it. You feel like you're getting a full breath and you feel satisfied. The biggest indicator that you need a change is when you're not feeling satisfied. Like you feel like you're having to pull in a little extra, you're doing a little more work to feel that full breath. Okay, and that's just an indication that we just need to bump up some pressures and maybe make some comfort settings as well. But yeah, definitely don't feel like, hey, like what Janie was saying, this was working and now it's not working as well. Especially with respiratory equipment, there's adjustments that we need to make, going along. So,
okay. And call your clinic team.
Call your clinic team, yes.
Definitely. My email, if anybody needs it, Janie, Janie, at alsaz.org. Rondo's is Rondo, RONDO, at alsaz.org, just in case you guys need to know that. Any other questions? All right. Thank you very much for coming. Gentiva Hospice has a little stand outside, so if you want any information about them, feel free to stop. She's got some information for you out there. Thank you very much.